Under the category Everything Old is New Again, this time it's atherectomy for peripheral arteries, and it's also sometimes used in veins and vein grafts. And I'm with Dr. Lawrence Garcia, St. Elizabeth's Medical Center in Boston, and we're talking about the definitive LE trial. First, what is definitive LE?
Definitive LE was one of the largest cohorts of around 800 patients that we enrolled in a registry, a prospective registry worldwide. It involved 47 centers, 3 in Europe and the rest in the United States, really assessing 800 patients, about 1,022 lesions for both claudication as well as critical limb ischemia. And the breakdown ended up being around 598 patients in the claudicant group and 201 patients in the critical limb patient group. The outcomes were driven by primary patency of the claudicant group, as well as critical limb ischemia was limb salvage. In that claudicant group, we also were pre-powered to assess the diabetic population compared with a non-diabetic population as to an outcome, i.e. Their primary patency at the end of that 12 months.
In that particular population, how did things go? Because the diabetics are a difficult group to manage.
Both from a coronary standpoint as well as from even a peripheral standpoint, the diabetics have been exceedingly difficult to get a similar outcome to their non-diabetic colleagues. And we've had a couple signals from an atherectomy standpoint that the diabetic patient population is treated equally well than the non-diabetic population. And in fact, definitive, in the breakdown, it was around 300 to the 200 diabetic, non-diabetic patients we assessed in the claudicant group had a similar outcome. In fact, we had a non-inferiority metric that we hit in the diabetic population. They did as well as their non-diabetic population. And the primary patency that we report is 79 and 78%. And understand that involves all anatomic territories, above the knee, at the knee, and below the knee. And when you separate out the location at the SFA, for example, or the popliteal or the infrapopliteal space, it still was a wash between the diabetic and non-diabetic. So a very clear signal that is pre-powered, so meaning specified as a scientific outcome in this study.
Why is this different? Because clearly elsewhere, diabetics and non-diabetics come out very differently.
I think it has something to do with the fact that atherectomy changes the arterial nature of blood flow. And by keeping a more smooth or a laminar blood flow, we may, and it may have to be proven more scientifically, but we may afford a more even-keeled response to that healing, which in the diabetic and the non-diabetic should be relatively equal. As long as we get a good atherectomy in regards to debulking size and get an appropriate size vessel with reasonable blood flow, then we actually can portend a better outcome in regards to restenosis. And what it shows is that as long as you do good work with good technique and get a good upfront benefit, then the downstream side is a better patent artery, which is our hope.
So with definitive results, who is this for now?
Well, that's really the quintessential question. You have a lot of us scientists who are saying that it has to be proven more scientifically, that atherectomy may be the best choice. But I think that definitive stands on its merits in the fact that it's an exceedingly robust trial. It had independent oversight for both the CEC and the steering committee. More importantly, it had angiographic and sonographic core lab adjudication, and these endpoints are hard. We had 2.4 metric PSVR is very comparable to all the stent trials, and just for an idea of where it sits in the landscape, for an SFA metric of around 6.5 centimeters, which was the SFA claudicant group, again both diabetic and non-diabetic, but 6.5 centimeters, which sits right in the sweet spot with other stent trials. Zilver PTX at a 2.0 metric was 83%. We were at 83%. The Resilient trial at just under 6 centimeters, we were 6.5 centimeters, it was 80%, we're 83%. So at the end of the day, I think definitive really can stand as a bulk first strategy, works. And the benefit to the patient is even when it fails, if it does have restenosis, the fact is you have every opportunity to treat with whatever you want to treat.
Right.
Whether it
doesn't take away anything downstream.
It doesn't burn one bridge. Exactly. You can still do more debulking. You could do drug-eluting balloon or drug-coated balloon. You could do stent. You could do a covered stent. Whatever you want is still very much afforded to you. The next big question is, because it's always going to come down to cost, is whether or not the debulking strategy, whether it's married to an anti-restenosis drug-coated balloon, which is occurring in Europe right now with definitive AR, if that combination is proven more beneficial, i.e. it's a better patency rate, then you can imagine that the cost analysis up front, although it may be more expensive, like drug-eluting stents are in the coronaries, downstream with a soft landing on primary patency is remarkably cost-effective. And that's ultimately where this debate will ultimately lead.
Well, we talked to Dr. Mark Turco about the science behind this. For somebody who was covering atherectomy in the coronary arteries some time ago, that's really interesting. So if you want to scroll up or down screen and find that interview with Dr. Turco, please do. For Dr. Lawrence Garcia, I'm Rick McGuire, Executive Editor of CardioSource Interventional News.